We will now hear from NET patient Mary on how she learned to deal with the common experience of scanxiety through living with neuroendocrine cancer for 15 years. After that, Dr. Michael Soulen, Director of Interventional Oncology from University of Pennsylvania Abramson Cancer Center, will give an overview on scans and liver-directed therapies. Dr. Soulen's practice focuses on liver-directed therapies, particularly for neuroendocrine tumors. He serves on the board of directors for the North American Neuroendocrine Tumor Society, or NANETS. Dr. Soulen is the principal investigator for the international RET-NET trial comparing bland and chemoembolization, and for the CAPTEM Y90 integrating chemotherapy and radioembolization for grade 2 neuroendocrine tumors. It's an honor to introduce NET patient Mary and Dr. Soulen.
Scanxiety is an ever-present reality in our lives. And as a 15-year pancreatic NET patient with well over 100 scans under my belt, I have definitely experienced my share of it. And having learned that as challenging as it is, it's a natural and necessary part of the process, the recovery, the growth, and the healing during a cancer journey. I know that you are all too familiar with the anxious state of mind that accompanies going in for that first scan after a cancer diagnosis, or maybe anticipating the results of a recent MRI, or the concern over the efficacy of your current treatment. As I write this, I realize I'm in good company with many of you as I wait for my next gallium scan, which I'll be doing in a couple of days, and lab results for a different medical concern. And as I experienced this recent bout with scanxiety, it occurred to me that the heightened level of stress is similar to what the entire world is really experiencing right now with this COVID pandemic. It's a collective grief and fear about our health, the unknown future, and the loss of normal. These are all emotions cancer patients are very familiar with. I found myself starting to fall into my same coping strategies, my past patterns way of dealing with stress. I was agitated, I was short with my kids and my husband, and I just was not very nice in general. All the while, I realized it was not very beneficial, and it wasn't even how I wanted to respond to the circumstances. But most significant was that I realized that I was not in control of the outcome of any of these things, but I was, so the outcome of my scans, the outcome of lab results, or the pandemic, but I was completely in control of my response. That's where the power lies, in our response. I'll be the first to admit sometimes it is utterly exhausting and overwhelming trying to find self-improvement when you don't even want to get out of bed. There are times when you want to be left alone, to be mad at the world, mad at your doctor, mad at your body, mad at your family even. We're all familiar with those days when you want to yell at the MRI tech for asking you for the 6th time that day what your birthday is, or cursing those strings on the double gowns when you're about to go in for your CT scan. What is undeniable that everyone has a different response, and nobody knows you quite like you. We're all feeling it to some extent right now. What a time, a perfect time to experience some self-discovery. First and foremost, you have to normalize the feelings that you're experiencing with a new diagnosis, new cancer treatment, new life since COVID. New rarely feels good or sits well with us, and in the process, you're grieving your old way of life. It can be a hard reality, but by naming it grief, it can help you to identify what you're feeling, and it gives you tools to overcome this. One quote that I just love from Brené Brown is, when you name hard emotions, it does not give those emotions power. It gives us the power to control them. And also, secondly, it's accepting your response. You might feel vulnerable, irritable, angry, withdrawn. We all know that. Withdrawing from your family and friends is not uncommon. But rather than trying to fight your body and your mind's reaction, acknowledge it and accept it. This is your response. And yet this response does not define you. Think about how you would support a friend who received a cancer diagnosis. We would show them a level of compassion and empathy that you never show yourself. When life becomes messy, It's the most challenging time and vital time to be kind to yourself. And it's pretty darn messy right now. And then in time, perspective comes. Some of life's greatest struggles come in the absence of accepting that change is totally constant in our lives. Now, this doesn't mean you have to like the changes that you're experiencing and the loss of normal that you're experiencing, but it is unavoidable. Pain without perspective is just completely unproductive. Perspective is gained by the expression of empathy for others and finding gratitude wherever you can, be it in the most seemingly insignificant things. Gratitude and perspective carry us a long way from life's grief and fear. I would like to leave you with my favorite quote that a friend shared with me when I became a diabetic 8 years ago. At the time, I remember being really upset with her and thinking that she didn't get it. But now I realize she got it much more than I could have imagined. Worry today won't change the outcome of your problems tomorrow. It only takes away your peace today. And I, for one, think we all need a little more peace. Thank you so much.
Hello, everyone. I'm Dr. Michael Soulen from the University of Pennsylvania in Philadelphia. Thanks very much to LACNETS for inviting me to speak to you all today. I'm the Director of Interventional Oncology at the Abramson Cancer Center, where I've been practicing for 30 years. And I primarily do liver-directed therapy for patients with liver metastases and primary liver cancers. And my major clinical interest is in neuroendocrine tumors, and most of my patients are patients with neuroendocrine tumors. I also was one of the founders of the Neuroendocrine Tumor Board at Penn. And my task today is to talk to you guys about imaging and liver-directed therapy in the management of patients with neuroendocrine tumors. So liver metastases are very common. They occur in 9 out of 10 patients with neuroendocrine tumors because the blood from where these tumors originate in the bowel and in the pancreas all drains to the liver. So it's the first stop for metastatic cells. So it's generally the first site of metastatic disease, most common site of metastatic disease, often the only site of metastatic disease in patients with neuroendocrine tumors. And even if there are metastases elsewhere, it's the tumors in the liver that tend to drive progression of the disease. And if you don't control them, then they eventually lead to death from liver failure. So when we're evaluating patients with neuroendocrine tumors for metastatic disease, the first step is cross-sectional imaging. We're talking about anatomical imaging as opposed to functional imaging, which we'll get to in the next slide. And when we talk about anatomical imaging, we're talking about things like CAT scans and MRIs, which shows us pictures of your plumbing and your anatomy. So in the chest, a simple CAT scan is sufficient. In the abdomen, things are a little bit more complicated because liver metastases may or may not show up in different phases of the scan, depending upon when the contrast was injected. So for example, if you look at the pictures, you're seeing 3 pictures. The left-hand picture is before contrast was injected, and you don't see much going on in the liver. In the middle picture, right after the contrast has been injected, what we call the arterial phase, you can see that large white area between the arrows, so that's a metastasis. But notice on the third picture, which is a scan done about 40 seconds later after the contrast has been given, that lesion just disappears. So you never know which phase people's tumors are going to be most conspicuous on. And so it's important that we get triple phase scans. Now, MRIs are always done in triple phase if you get contrast, but CAT scans routinely are done with only a single phase of contrast. So it's very important if you're getting a CAT scan rather than an MRI that it be done triple phase. And then for imaging the pelvis, again, a CAT scan or MRI is fine, and those can be done in just a single phase of contrast. So typically, people will start out with their abdomen triple phase and then go back and just scan the pelvis after they're done getting all 3 sets of pictures of their liver. And that gives us a very good idea of how big the tumors are, how many they are, where they are in the liver and also other parts of the body. Now, the other imaging technique that's commonly employed is gallium imaging or PET-CT. So this is what we call functional imaging. It's not so much anatomical imaging, meaning that the anatomy is not as well seen. And what we're doing is we're injecting patients with radioactive sandostatin. The radioactive sandostatin sticks to receptors on the tumor cells, just like regular sandostatin does. And then it's tagged with gallium, which is a PET imaging agent, and which will glow hot in places where there's uptake. So you can see the picture on the slide. The background's a little fuzzy, but you see those bright yellow orangish spots. Those are areas of uptake in neuroendocrine tumors. this is not something that's initially done for everybody, but we have certain indications for when it should be done. And these are listed as appropriate use criteria. These are criteria for doing gallium PET CTs that Medicare will pay for. And that includes diagnosis for masses that we can't biopsy, the initial staging when you're first diagnosed with a NET. For people who present with metastatic disease and we don't know where the primary tumor is, we don't see a primary tumor on CAT scan or MRI, we can do a gallium scan. If we're planning major surgery to debulk or cure somebody, we'll do a gallium scan just to be sure there's not a lot of other disease that we did not see on a CT or an MRI. And of course, if we're thinking about doing PRRT or peptide receptor radiotherapy, which is the exact same compound that's used for the PET CT, only it's labeled with lutetium instead of gallium, then we need to know whether your tumors are avid or not. A couple things to keep in mind. Patients frequently throw out the phrase gallium scan as a shorthand for this. It's important to realize that gallium is just the isotope we use for the pictures, and it's used in other kinds of PET CTs for other diseases like prostate cancer. So I have had patients who showed up for their gallium scan and got the wrong gallium scan. So the important thing is that it's somatostatin receptor PET imaging or dotatate PET imaging. Gallium is just the radioactive agent that's used. Once we have pictures that show us that metastatic disease is present, then we're going to want a biopsy. And this is for a couple important reasons, one of which is tumor grade. So tumors, when we biopsy them, we look at them in the microscope, we count how many cells are dividing, and we also do a special stain called Ki-67. And you don't have to pay too much attention to the numerical details on this chart, but basically based on the Ki-67 stain and the number of, they would call the mitotic index, which is the number of cells that are actually dividing, we divide patients into grade 1, 2, or 3. And in grade 1, only a couple percent of the cells are growing or staying with Ki-67. For grade 2, it's 2 to 3 to 20%, and above 20% is grade 3. And we use this information to help us prognostically, because the higher the grade, the faster the growing the tumor is going to be, and that will change the prognosis for the patient. And to a certain extent, it will affect our decisions about what kind of treatment to offer. So grade is very important, and everyone should know their tumor grade. Now, the other thing we can do with the biopsies, and you may or may not see this in reports, is do other special stains other than Ki-67. And these are looking for markers that help tell us where the tumor came from. So, sometimes we know where the primary tumor is, but sometimes we don't. And these extra special stains like TTF1 or CDX2 help tell us that, oh, this tumor may have come from the lung, or it may have come from the pancreas, or it may have come from the intestine. And so these additional information we get from the biopsies can help tell us where the tumor came from, which also affects decisions as far as treatment. And this little panel of these 3 markers is about 80% accurate in figuring out what the origin of the tumor is. Okay, so once we have you diagnosed and we have your biopsy information, how do we treat you? And that will depend upon how you present. So these are the NCCN guidelines for treatment. They're just being updated now, so they'll be updated again in 2020, probably released this summer. But I think the basics that you're going to see here from 2017 have not changed. So if you present with a low burden of liver metastases and you're not symptomatic, often we can just do surveillance, especially for low-grade tumors, grade 1 tumors, which things aren't going to change very quickly. You can just start doing surveillance with MRI or CT scans of your liver. And typically we do every 3 months for the first year. If you're stable at a year, we can back off to every 4 to 6 months. And if you're stable at 2 years, we'll definitely go to every 6 months. Many patients will be put on either octreotide or lanreotide, monthly injections, right from the beginning. Although, in fact, if you have a low tumor burden and you're grade 1, it's reasonable to hold off on starting shots until we know that your tumor is actually progressing, because some patients have such indolent tumor that even over a year, nothing will change, and you just spared yourself a year of getting shots every month. Irrespectively, if you have symptoms from your tumor or the tumor showing any signs of growth, then you would definitely start with octreotide or lanreotide shots as your first treatment. And then again, serial scans, MRIs or CTs every 3 months to see if the shots are keeping the tumor from growing. And there are some patients who do very well with this. I've had patients who show up in my office with pretty substantial liver tumors, 5-8 centimeter tumors that you just think are absolutely going to have to be treated aggressively. and you put them on octreotide or lanreotide, and they stabilize for 5 years. So that's the first line of therapy. Now, if you start your octreotide or lanreotide and you're still symptomatic in terms of hormonally induced symptoms from the tumor, or your tumor grows, then we have to move on to some other therapy. So if it's a matter of symptoms such as diarrhea or flushing that are not controlled with octreotide or lanreotide, we can add talatrestat. And talatrestat may help a lot of those patients with symptom control. This has nothing to do with controlling the growth of the tumor. If that doesn't work, so you still have symptoms despite octreotide, lanreotide, and or talatrestat, or we have pictures that we've been doing every 3 months that show your tumor is progressing, then we have to move on to the next stage of treatment. And that's going to be consideration for liver-directed therapies for liver metastases. So those could be surgical debulking or ablation, or some form of embolization. So what's the basis for embolizing the artery to the liver? This all goes back to the 1950s when people realized that the blood supply to tumors in the liver was different from the blood supply to the liver itself. So the normal liver gets 3/4 of blood supply from the portal vein, which is that large structure in blue you see there. It's a huge vein the size of a hot dog that drains the blood from your entire GI tract to your liver. That's also how the tumors got there in the first place. So the normal liver gets 3/4 of its blood from that huge vein and 1/4 from the smaller artery you see in red there, which is the hepatic artery. Now, it turns out the tumors, when they grow big enough to be seen on CAT scan or MRI, get almost all their blood from the artery and very little from the portal vein. People, once they figured that out, even back to the 1960s, started trying to treat neuroendocrine tumor metastases by cutting off the blood supply to them. Initially, by surgery, they would just tie off the hepatic artery and cut off the blood flow. And then a little bit more elegant approach, which was embolization, or catheterizing the artery and then injecting material directly in the artery to cut off the blood flow to the tumors. So what's important to me when I'm planning therapy for a patient is your plumbing. Your liver actually has 8 segments, and every segment has its artery and its vein and its bile duct. So I need to know which segments of your liver have tumors and which segments don't, so I know which parts of the liver need to be treated and which parts can be spared. Also, the plumbing of the liver in terms of the artery is quite variable. So you have a right lobe with 4 segments and a left lobe with 3 major segments. In the simplest case, each of those lobes has 1 artery, but only about half of people have simple plumbing and half of people have more complicated plumbing. So we have to sort that out so we know where the blood's coming from to each segment of the liver that has the tumor. So this is a little bit of a complicated video, but it just kind of shows you what we're doing in the room while you're there snoozing on the table. You're going to hear the voice of one of my colleagues in the background.
I don't want to have too much reflux.
So we're mixing our chemoembolic material. We're staring at an X-ray screen where we see our catheter and we can see the stuff we're injecting. We do fancy CAT scans in the room and do 3D reconstructions that show us our catheter and the blood supply to the tumors. And this allows us to sort of elegantly map out in the procedure exactly where the tumors are and what branches of your arteries are feeding those tumors, so we can direct our therapy as specifically as possible to the tumors in the liver and spare as much normal liver as possible. So here's just some still pictures. So on the top left, figure A, what you're seeing is a CAT scan, and sort of in the middle there in the liver, you can see a dark spot, which is the tumor. There's a little white arrow pointing to it. And then in figure B, what you're seeing is what I see in the room, the arteriogram. So this is a catheter that's been placed in the artery of the liver. We're injecting the X-ray dye, which shows up as black. We're seeing the branches in the liver with the short white arrowheads pointing to the artery to the left lobe. And then the larger white arrows are pointing out exactly where the tumor is within the liver that matches what's on the CAT scan. And then in figure D in the bottom left, what you're seeing is the chemoembolic mixture that's been injected. So now we have our catheter way out in the liver. And again, those same 3 white arrows are pointing to the tumor. And the black that you're seeing is the chemoembolic goo we've injected through our catheter and to saturate the tumor blood supply in that portion of the liver. And then the bottom right picture, figure E, is the CAT scan of the exact same patient after treatment. So you can see before treatment, the tumor was darker than the rest of the liver. Now that tumor lights up bright white because the chemoembolic material has iodine in it. The iodine showed up as black on the angiogram, but shows up as white on a CAT scan. And you can see that tumor is completely saturated in the chemoembolic material, and all its blood supply has been cut off. The next question is, when do we initiate liver-directed treatment for patients with metastatic neuroendocrine tumors? So there are a couple clear indications. One is if you have symptoms that are refractory to medical management. So if you have flushing or diarrhea and it's not being controlled by octreotide or lanreotide or telotrestat, then that's a good indication for embolizing your liver metastases to shrink them down and decrease the amount of hormone secretion. And as we'll see in a moment, that works quite well. Deterioration of liver function tests. So if the amount of tumor in the liver is causing the liver not to work well, then it's very important that we get that tumor under control, because you can't live without your liver. And although your liver has a lot of reserve, if you start to lose that reserve, then that's why many patients die from this disease. Tumor bulk greater than 25% of liver volume. So if you show up and you already have tumor taking up a quarter or more of your liver, even if you feel fine and your liver's still working well, we generally say we should start debulking therapy, whether it's surgery or embolization at that point, because we don't want to wait for the tumor to grow and take over the rest of your liver. Neoadjuvant for hepatic resection, what does that mean? Well, sometimes we want to think about just debulking surgery to remove as much tumor as possible. But if you present with just a little bit too much tumor, or maybe the tumor is encroaching on some important veins that the surgeon needs to preserve, sometimes we'll embolize first to shrink down the tumors and give the surgeon a little bit more room, and then they'll go in and operate. And then the controversial group, the people that it's hardest to make a clear-cut decision on, is patients who show up with a low tumor burden, especially grade 1 patients. So they have less than 25% of their liver affected by tumor. They're not symptomatic, but the tumors are clearly progressing. So then the question is, when do you pull the trigger? Because we know this treatment works well, but you only get to get embolized so many times in your life. And the question is, when do you pull the trigger on the first one? Now, there are some places that say any progression of disease is an indication to do your first embolization and get things under as best control as you can, and then go back into surveillance mode. Other people, including myself, a little bit more conservative, and if I look at your scan and you're 95% G's and 5% holes, I really don't want to shoot my first embolization now, because you're going to be fine for months or maybe years. So I'd rather wait and watch, even if you're progressing slowly. And sometimes that progression, evolves over 2 or 3 years. So often you can be patient and wait a little while until you sort of reach a mutual agreement between the patient and the doctor, said, okay, now it's time to play whack-a-mole and let's knock off as much of these suckers as we can. And then go back into surveillance mode. And then you have the same pattern, because you get embolized the first time, your tumors mostly die. Over a series of scans, they will shrink and shrink and shrink until you get to the new you, a new plateau. And then you'll probably be stable for a while, a series of scans. And then eventually something will start to wake up. Either a tumor that didn't die the first time will start to grow a new blood supply, or maybe new metastases will appear. And then you're faced with the same situation. Do I treat now, or do I just watch it for a while until there's sort of enough tumor that it's worth it? And ideally, you like to string these treatments out, 2 or 3 years between cycles of embolization if possible. All right, so how well does embolotherapy work? So does it control symptoms? It turns out it's great for controlling symptoms. If you have flushing or diarrhea or other hormone-related symptoms, and we embolize your liver metastases, even if there's disease outside the liver, about 85% of people will resolve their symptoms after embolization. So, and part of it's because you're just debulking a lot of tumor at once, even if there's disease outside liver. And part of it is because the tumors in the liver are secreting the hormone directly into your bloodstream, where it has its most impact. Tumors in your abdomen, that what the hormones they secrete go to your liver, and they can get metabolized there. So in any event, embolizing the liver works great for symptom control, irrespective of whether the tumors are growing or not growing. Does it debulk disease? Meaning, does it shrink the amount of disease significantly? And the answer is yes, most of the time. So 55, 60% of the time, you will get significant shrinkage of your tumor. And we have very strict criteria for what defines that after embolization. Now, even for the patients who don't get significant shrinkage, meaning 30% or more, most of them get some shrinkage of their tumor, or at least it stabilizes. So very few people will not respond at all to embolization or progress despite embolization, although that can happen. But the actual tumor control rate is probably 90 to 95%. So if you get benefit, how long does it last? That will actually depend a lot on the grade of your tumor, but the average is around 1.5 years after embolization before you start seeing recurrence of disease. Now, if you have a higher grade tumor, it may be less than that. So a grade 2 tumor is average closer to 1 year, and a grade 3 tumor will be less than 1 year. So that will be some variability, but generally you're expecting fairly long-term benefit after embolization. How about patients who have disease outside their liver? As I said before, most progression occurs in the liver, even when there's disease outside the liver. So if I took a group of patients and waited 2 years, about 7 out of 10, the tumor will progress by 2 years. And, 6.9 out of 10 of those, the progression's in the liver. So it really is the major driver of progression of disease. And so treating the liver is highly beneficial, even in patients with disease outside the liver. What about the risk? So, chemoembolization and bland embolization aren't, I can't say they're a lot of fun, but they're basically have a very low rate of severe toxicity. Almost nobody dies from this therapy. Most people get post-embolization syndrome, so variable degrees of pain or nausea or fever. And many people will stay at least in an observation unit overnight and go home the next morning. Some people will be done as an outpatient. And in terms of major complications, those are quite uncommon, less than 5%. So you have some choices. Obviously, liver-directed therapy is not the only choice. We've talked about how well it works. So most patients respond. The time to progression is about 1.5 years, and the toxicity rate is pretty low. Some of the other alternatives include targeted agents like everolimus, which has a very, very low response rate, a much shorter time to progression, and is a hard drug for people to tolerate. Most patients need to have dose reduction. For patients with pancreatic neuroendocrine tumors, we have pretty good data relatively recently on CAPTEM, combining capecitabine or Xeloda and temozolomide or Temodar as an oral chemotherapy regimen. That has a response rate in about 1/3 of patients that lasts between 1.5 years and 2 years. And a fair amount of toxicity, but usually that toxicity can be managed by adjusting the dose of the drugs. So we're actually big fans of CAPTEM at Penn. We use a lot of it in appropriate patients. And then, of course, we have PRRT, which has a pretty low response rate, less than 20% in terms of significant tumor shrinkage, but it's very good for tumor control. So the time to progression on average is more than 2 years. The toxicity is quite low if you look at the large series from Europe, where they've been doing this for a long time. It's been somewhat higher in the US, and a lot of that has to do with the fact that it just recently became available in the US in the last couple of years. So we're treating a lot of patients with more advanced disease who don't tolerate it quite as well. And so we know that people who have heavy tumor burden or liver dysfunction at baseline don't do as well with PRRT. But if you do it earlier in the course of disease, people tolerate it quite well. So when you're trying to decide what to do, you're weighing the pluses and minuses of each of these therapies. Our general philosophy at Penn, overall in the tumor board, is that you should do localized therapy for localized disease as long as possible. We're very good at controlling liver metastases with liver-directed therapies, be it surgery or ablation or embolization. And, if we do that for long enough, sometime down the road, maybe in 5 or 10 years, tumor will start showing up in other parts of the body. And then you want to do your systemic therapies like CAPTEM or PRRT. So for patients who present with liver-dominant disease, we prefer to start with liver-directed therapy and save the systemic therapies for later. So that's one philosophy. You also have to look at what the goals of care are of the individual patient. So, if you need debulking, if you want to significantly reduce the burden of tumor, then you need surgery or embolization. But if what you want is prolonged control and you don't need, so people present with a lower tumor burden who don't need necessarily to be debulked, but what you like to do is sort of keep them there for a long time, then you get more sustained benefit with the systemic therapies like CAPTEM or PRRT. So you're going to customize your decision to the individual patient. But these are some of the pros and cons of the liver-directed therapies versus systemic therapies. So if you decide to do liver embolization, how are you going to do it? And there are a number of choices that have been out there historically for decades. So we started initially what's called bland embolization, meaning we just catheterized it out of the liver, and then we injected some sort of solid particles, which there are many kinds, to cut off the blood flow of the tumors. So that's now called bland embolization. That dates back to the 1970s. In the 1980s, people started mixing chemotherapy in with the embolic material. And the idea is that you would cut off the blood flow of the tumor, but you'd also deposit super concentrated chemotherapy into the tumor itself, which would then get stuck in there for weeks. So that's chemoembolization. That's been around, as I said, since the 1980s. And it comes in two flavors. One is conventional chemoembolization, where the drugs are mixed in an oily contrast agent called lepiodol, and then that emulsion of oil with drugs is injected to saturate the tumor. That's the white stuff you saw in the CAT scan I showed you. And then you inject some particles at the end to just cut off all the blood flow coming in, so your liquid phase stays there. And that's the historical form of chemoembolization that everyone's done since the 80s. DEB-TACE, or drug-eluting bead TACE, or sometimes called DEB-DOX when you use doxorubicin, is a newer formulation. It's been around since about for the last 10 years, where instead of injecting the chemotherapy drugs in the liquid phase, instead they're loaded on to the little microsphere, the little beads we use to cut off the blood flow. And the idea is that the drug will then stay with those little pellets. They get stuck in the liver, and then the drug leaches off. Either way you do it, the main thing you're doing to kill the tumor is cutting off the blood flow to that part of the liver. And the tumors will mostly die when you do that. The liver will survive because it's getting its blood from the portal vein, but the liver doesn't really like having its arterial blood supply choked off. So most people get post-embolization syndrome, as I mentioned. They get variable degrees of pain or fever, nausea. They have to stay in the hospital overnight. And when you go home, most people have variable degrees of fatigue and loss of appetite for 2 to 3 weeks, highly variable. I mean, some people go back to work the next day. Some people feel terrible 4 weeks later, but most people have a short-term, almost a flu-like syndrome that goes away within a few weeks. And the tumor, of course, dies immediately because you've cut off its blood supply. So the catheterization procedure, it kills what it kills that day. So I sometimes tell patients this is quick and sick. You get in, you get catheterized, your tumor gets killed. You're going to be a little sick, but you'll get over it. Another alternative therapy that's been around for the last 15 to 20 years is radioembolization, sometimes called TARE instead of TACE. And now, when we catheterize the liver, instead of cutting off the blood flow, we instead inject millions of little tiny microscopic radioactive beads or seeds. And these go out and get stuck all through the tumor and in the liver. And then they emit a very heavy form of radiation that can't travel very far, only a few millimeters. So essentially, you're radiating the tumor from the inside out. This is similar to the idea of men getting seeds put in their prostates for prostate cancer, except we're instilling millions of seeds into the liver through the artery. Now, because we don't cut off the blood flow, patients don't get as sick. So you can do it as an outpatient, don't have to stay overnight. Half of patients have no side effects at all. And the most common side effects are the ones from the radiation, which can be fatigue or nausea, but not from the embolization procedure itself. Radiation works quite slowly. So the tumor doesn't die the day you do the treatment, it dies over months. So you can't even see a response until 3 months later. So I tell patients this is slow and glow. It's a slower procedure, it works more slowly, it uses radiation, but it has less side effects and less disruption of quality of life. So what do people do? Well, this is a survey that was done actually now about 8 years ago. And where they're asking interventional radiologists, what technique do you use for various kinds of cancer? I just draw your attention to the box in red, which is neuroendocrine tumors. And you can see it's pretty much a wash. It's an even division between radioembolization, bland embolization, conventional chemoembolization, and drug-eluting beads, at least as of 8 years ago. Whereas the other tumors, there seem to be very strong biases toward one technique or another. And what this reflects is that we really don't know whether one of these techniques is in fact better or worse than the others. At least we didn't 8 years ago. So we're trying to answer this question now. And one of the ways to answer this question is the RETNet trial. So that's a randomized embolization trial for neuroendocrine tumors. I'm the global principal investigator for this study, which is being run in North America, South America, and Europe. And the idea when we started was to take patients who needed to have their liver tumors embolized, and we randomized them to either bland embolization, conventional chemoembolization, or drug-eluting beads. And we're asking 3 questions. Is one of these techniques actually more effective? Is one of these techniques more or less toxic in terms of side effects and complications? Or is one of these techniques better or worse in terms of the patient-reported outcomes in terms of quality of life? So we're looking at all 3 of these things for all 3 of these treatments. So the trial's about half accrued, and one of the things that was part of the trial was to do safety analyses at regular intervals. And so we did our first safety analysis when we had 10 patients in each of the 3 arms. And it turned out that 4 out of 10 patients who got drug-eluting beads had major complications. A couple of them ended up in the intensive care unit. A couple had to stop the therapy because of the complications they had. And so that crossed the threshold for safety that was allowed in the trial. So we actually closed the drug-eluting bead arm after just 10 patients because the complication rate was so high. Now, one of the reasons why we did such an early safety analysis after only 10 patients is that we were worried about this because there had been another trial a few years ago. It wasn't a randomized trial. It was just a single-arm trial of drug-eluting beads in neuroendocrine patients that all had the same problem. And in fact, it closed after about 13 patients because of the high toxicity rate. So we basically confirmed what that other single-arm study showed and also confirmed what had been reported in larger retrospective series from some institutions in Europe that also were seeing these high complication rates. So this trial has already taught us something, that drug-eluting beads is not a good platform to use in neuroendocrine tumors, and that will affect the guidelines for treatment. What about radioembolization versus bland or chemoembolization? So there's some pros and there's some cons to using radiation-based therapies in metastatic neuroendocrine tumors. The major pro has to do with patients who've had a Whipple or had a biliary stent in place. So one of the things that we learned many years ago was that if you've had a Whipple or a bile duct stent, so you don't have an intact biliary tree anymore, and you do bland embolization or conventional chemoembolization, there's a very high rate of infection. In fact, the rate of a liver abscess, even with giving major antibiotics for weeks, is still about 20%. So it's a major complication that can occur unique to patients who've had a Whipple or a bile duct stent in place. And the reason for that is that normally your liver is a sterile place, your bile is sterile, and it flows down through your bile duct, and there's a one-way valve at the bottom of the common bile duct that allows the bile to mix with your food to help digestion, but doesn't allow the contents of your gut to get up into your liver. And once you've had a Whipple and they've cut your bile duct, or you have a stent put in there, you no longer have that valve. And now the bacteria that normally live in the gut colonize the liver, which is okay until we embolize you. But once we embolize you and you get that microscopic injury from the embolization, the bugs get in your liver, you can get an infection. So it's a big concern for us doing embolization or bland or chemoembolization in patients with Whipples or biliary stents because of the infection risk. You can still do it, but you're going to get an abscess 20% of the time. Now, with radioembolization, we're not cutting off the blood flow. So we're not cutting off the blood flow to the bile ducts either. And it turns out that the rate of infection is much lower in Whipple patients or biliary stent patients. In fact, in Penn, we've never seen one. And after I published that, we then did a large multi-center study in the United States of about 80 patients. And it turns out the rate wasn't 0, but it was quite low. Maybe 7% of patients got infection after radioembolization versus the 20% with chemoembolization. So in patients who've had a Whipple or biliary stent, I will go with radioembolization as my first-line therapy, and I'll save the chemoembolization just in case the radioembolization doesn't work, just because it's safer. Another possible advantage of using radiation-based techniques is combinations with chemotherapy. So it turns out that CAP-10, the oral chemotherapy drug combination that works so well in pancreatic neuroendocrine tumors, are both radiosensitizers, meaning they're drugs that make radiation work better. And in fact, they're commonly used combined with radiation therapy for other kinds of cancers, such as GI tract cancers and brain cancers. So at Penn, several years ago, we started saying, well, why don't we combine the two? Why don't we give CAP-10 to patients who are also getting radioembolization? And we did that uniquely for patients who were somewhat higher risk. So our grade 2 tumors who had liver-dominant disease, but they also had disease outside their liver, so there's a reason to give systemic therapy. And because they're grade 2 tumors, they're not going to get quite as durable benefit from either one of these alone. So we said, well, why don't we combine them? So we did a pilot series of about 20 patients. And it turned out they tolerated the combination of getting CAP-10 while getting radioembolization quite well. The response rate was remarkable. It was about 75% of the patients responded to the treatment in terms of significant shrinkage. And even more importantly, that response was incredibly durable. In fact, we haven't reached even the halfway point of people progressing yet at close to 3 years. So we're very encouraged. Now, that was just a phase safety and feasibility study, just 20 patients. But we're now doing a multi-center phase 2 study of a large number of patients to better establish how well this treatment combination works. So that's another reason, that's sort of a pro for thinking about doing radioembolization, is the ability to combine it with chemotherapy in selected patients. Offsetting that are the potential problems with radiation-based therapies. And the one that I'm most concerned about is that 3 centers, including my own now, have reported late liver failure in 10 to 20% of patients who live a long time after radioembolization, particularly if they have radioembolization to the entire liver, both lobes of the liver. And so these are all just retrospective series from single institutions. So they're thought-provoking, not definitive, but if you look at patients who live for a very long time after liver-directed therapy, and neuroendocrine patients do live a long time, unlike other cancers we treat, a certain percentage of patients eventually go on to develop liver failure. Now, most commonly, that's due to progression of their tumor. But if you look at that whole group, if you take out all the patients who clearly had progression of cancer as the reason their liver failed, and you take out anyone who had something else happen that might have caused liver failure, we were still left with between 10 and 20% of patients who went into clinically significant liver failure. And in fact, at Penn, 5% of our patients died from liver failure, even though their cancer was controlled. And that didn't happen until many years after they were treated. So that's a concern, specifically in neuroendocrine patients, and another reason why we tend to kind of keep radioembolization on the back burner, except for the higher risk patients, like people who've had a Whipple, and rather go with bland or chemoembolization first. Now, another conversation that you'll frequently run into along these lines with your doctors and maybe in your patient support groups is it safe to have radioembolization and PRRT? After all, they're both involved giving you radiation. And although I hear that a lot, there really is zero evidence that it's bad to combine the two. There's been a lot of experience for many years in Europe doing both these procedures. We haven't had PRRT quite as long in the United States, but there's lots of experience out there, and lots of people have done both PRRT and reembolization in either order, and there really is no evidence that there's any combined toxicity between the two. So, although I hear people talk about this a lot, and they want to don't do reembolization because I might want PRRT someday, we really don't have any evidence that that's actually a problem. But I am more concerned about, irrespective of PRRT, late side effects from reembolization. Okay, so let's sum it all up. When should you get liver-directed therapy? If you have uncontrolled symptoms, if your tumor burden is greater than 25%, or if you're progressing on octreotide or lanreotide. How should you get it? I think bland embolization or chemoembolization is first line unless you've had a Whipple or a biliary stent. Between bland embolization and chemoembolization, we don't really know, even after all these decades of doing it, if there's a difference. And the RETNet trial is going to help answer that question. So if you're just starting out and you're at a center that's part of the RETNet study, please sign up for the trial. You'll be helping yourself and you'll be helping others. Reembolization, again, in just selected patients, although I am concerned about a long-term risk of liver failure, and definitely should not get drug-eluting bead embolization. And then, is this a standalone therapy? You're going to combine it with something? Well, it certainly can be a standalone therapy, but you can also think about combining it with systemic chemotherapy, systemic radiotherapy like PRRT, biologics, or surgery. And because of the complexity of this decision-making, you need to be in a major net center that has a tumor board, where we can all sit around the table with all the experts and map out an optimal plan of care for every patient. Thank you very much, and I guess we'll have a discussion period later.
Thank you, Dr. Soulen, for the thorough review of scans and liver-directed therapies, and thank you, Mary, for encouraging us with your story. Our next speakers are on the popular topic of PRRT. To many of us, myself included, this is a very important topic because we have either had PRRT, are currently undergoing PRRT, or are considering having it sometime in the future. In fact, it was because of what my husband and I learned and connections we made from NET patient educations, conferences, and meetings that helped prepare and guide us for our own experience with PRRT. We will now hear from NET patient Shaunie and her daughter Heather, who will share their experience with PRRT. We will then hear from special guest Dr. Erik Mittra from Oregon Health and Science University. Dr. Mittra is very active with the Society of Nuclear Medicine and Molecular Imaging, SNMMI, and the North American Neuroendocrine Tumor Society, or NANETS, and serves as the current medical director of the Healing Net Foundation. The Healing Net Foundation may sound familiar to you since we heard from the co-founder and executive director, Cindy Lovelace, earlier today. Dr. Mittra was involved in both NETTER-1, the large-scale clinical trial that led to the FDA approval of Lutathera, and he was also involved in the recent NANETS SNMMI consensus statement on patient selection and appropriate use of LU-177 dotatate PRRT. Thank you for being with us today.
Hi there, my name's Heather and this is my mom Shaunie, and we've been on her neuroendocrine cancer journey together for almost exactly 8 years now. It was July of 2012 when she was diagnosed with pancreatic neuroendocrine cancer. So her primary is her pancreas, which she had the distal portion of removed surgically back in 2012. And since then, she's been through quite a lot of treatments. Initially, it was octreotide, followed by some oral chemo medications or biologics, and progression did continue. There was metastasis in her liver about a year or so after the cancer was found in her pancreas. And being the zebra that she is, liking to be rare and unusual, we did also find out, unfortunately the hard way, in late 2017, that her tumors are indeed functioning, and she has what's called Zollinger-Ellison syndrome, which her tumors produce a hormone called gastrin, and that gastrin stimulates stomach acid to a pretty outrageous level. So in late 2017, her small intestinal duodenum ruptured, and she was hospitalized for about a month. They didn't know whether or not it could heal itself. She was on a feeding tube for a few months and made it through that. And fortunately, we had hope during that time that the trials were going well for PRRT and Lutathera. And when that was approved in January of 2018, that was our goal, as the cancer had also metastasized a bit to her lung as well. So we were looking for systemic treatment and really hopeful that PRRT was going to get there in time. She was able to start Lutathera at Stanford Cancer Center, and that was in mid-October of 2018. She's undergone all 4 rounds and has been finished with PRRT for just over a year now that it's been. And fortunately, I know that we were very concerned about the nausea and the vomiting. Stanford Cancer Center, however, did have the compounding amino acids that made all the difference.
Great difference.
And not only was she not nauseated, but
yes, I must admit, I was really scared to try a treatment that involved radioactive drug, but it was by far the easiest treatment I had received. And the most painful part was just getting the IV put in.
She's a hard stick. She's a hard stick.
But then I didn't experience any nausea. I was, like you say, able to eat a light lunch, have a Jamba juice, and the only side effect I experienced was just fatigue. And then the hardest part for me was having to stay away from adult family members for 3 days, and then no contact with my grandsons for 7 days, which I really miss them. But overall, I was very fortunate that I didn't have any bad side effects.
And results-wise, the scans weren't necessarily impressive in reduction of the tumor size or the amount of tumors. Definitely just considered stable throughout the scans. We're definitely due a few months ago for her scans now, but thanks to COVID, those are a bit delayed. But stable was good. The biggest thing, though, and the life-saving difference that we can say it made was in the functioning portion of those tumors, and the PRRT and Lutathera essentially turning those off. So her level of gastrin initially when it was discovered was 17,000. And then before she went to have PRRT, it was still at 7,000, well over 7,000. And only 1 month after that first initial dose of Lutathera and PRRT, it was reduced down to 2,500. And then even now, a year after her full 8-month course, it's in the low 300s. So it's in like the 300s to 500s, which is a drastic difference and makes all the difference as far as the stomach acid levels and safety for her, and also made such a difference. I can say for sure, since you were first diagnosed in 2012, this past year and a half to 2 years of being on the treatment, you're like your old self.
Oh, Yeah, I'm so grateful that I can personally share my experience, and I testify that the difference it has made in my overall health and well-being has been amazing. I feel good. I can do the things I enjoy doing, including walking and playing with my new border collie puppy. And I've witnessed so many miracles these past few years, but I can definitely count Lutathera or PRRT as one of the greatest miracle, and I'm so grateful I was able to receive the treatments when I needed them.
And we know everyone, again, you're all zebras. Everyone's on a very different, unique journey. We wish you all well, and we do hope that PRRT is something that will be able to make a difference and a really good treatment for you as well. And we wish everyone
success and
success and the best.
Yes.
Thank you.
Thank you.
Hi, everyone. My name is Dr. Erik Mittra from Oregon Health and Science University. I'm a nuclear medicine physician there, and I've been very involved in neuroendocrine tumors for a long time. So thank you very much for this invitation to the organizers for having me. And I'd like to talk today about peptide receptor radionuclide therapy. So the outline for this talk is that I'll discuss this concept of theranostics, which is very big in our field right now. And the topic of this presentation regarding PRRT is actually a great example of it. So after that introduction, I'll discuss the imaging aspects of this therapy, then discuss the therapy itself in more detail, discuss about some future areas where this will go, and then also mention some closing comments on PRRT in the COVID-19 era. So this is a very basic slide that very nicely describes what we do in nuclear medicine, which is that we identify a target expressed on a cancer cell, and then we find an agent that will bind that target, use a linker to then associate a radioisotope to that agent so that we can either do imaging or therapy based on that cancer target. And all we do is we replace that isotope with either a type that allows us to do imaging or another type that allows us to do therapy and will actually damage the cancer cell. So that same concept is now expressed in this larger diagram, which shows that patients, one at the top and one at the bottom, can both be imaged by this same radiopharmaceutical to identify whether or not they express the target appropriately. And the one on the bottom does not, and so would not be amenable to doing this therapy. And that's very helpful to know that right away so that we don't waste any time or give this therapy to something that would not be useful. The patient on the top that's shown does show the expression of the receptors appropriately. And then we use the other version of that same agent, a isotope that will actually cause damage to those cancer cells. And then we can subsequently again image with the same agent, going back and seeing whether it actually had an effect, and ultimately, hopefully, going to a point where the treatment is complete. So this ability to do both therapy and diagnostic imaging together gives rise to this word theranostics, which is literally the combination of those two words. And it's a very powerful concept in our field right now. And there's actually many different therapies that are going to be done based around this concept. So when we talk about neuroendocrine tumors, again, this is a perfect example of what I just showed you in a general schematic sense. Because we know of this target of somatostatin receptors that is overexpressed on a large number of neuroendocrine cells, the human somatostatin molecule is used to communicate between those receptors normally. And a long time ago, an abbreviated or shortened version of this human somatostatin was created, which is called octreotide. And of course, you're likely familiar with that as something that's used very commonly for symptom control for neuroendocrine, as well as helping to control the disease itself. So all the versions shown on the bottom, C through F, are then different examples of using that octreotide, which binds to the somatostatin receptor, but then, as I showed you, applying different radioisotopes to be able to do imaging or therapy based on that targeting to the neuroendocrine cells. So for a long time now, we've been doing octreoscan imaging, which is now considered the older version of imaging, which attaches a gamma emitting isotope to the statin receptor. And we've been using it for a very long time to be able to image patients who have the disease and then watch the effect of the therapy and then follow subsequently over time to see if it comes back or not. But now, with the advent of the PET imaging agent, which uses the same receptor binding, you'll see in this example why everyone has really moved over to PET imaging over the gamma imaging previously. So in this example, this patient had a single focus that was seen in the left upper chest there or in the left low neck. That was based on octreoscan imaging, but then when we did the dotatate PET scan on the same patient, you can see that not only see that one area of disease, but we can actually see disease in many other sites throughout the body as well. And it was findings like this which really pushed forward the approval of dotatate PET and really has become the imaging agent of choice. And all patients who are being considered for PRRT need to have this scan done to confirm appropriate expression of the somatostatin receptors before we can move forward with the therapy, as I showed you in that theranostics diagram. So really, in every regard that you compare octreoscan, the older imaging, to the newer dotatate PET, it's better. So the prior one had lower resolution. This one has higher resolution. The prior scan took a minimum of 2 days to complete, whereas the newer one takes a maximum of 2 hours to complete. And then the radiation dose is much higher with the older version than with the newer version, almost 3 times lower. And the only thing that you can say about the older one is that it's available literally everywhere, whereas the newer one, because of the short half-life of the isotope, it's available in majority of places, but it's not available everywhere. So in those places where it's not available, then the other version is still available and really serves the same purpose. I will mention that our other standard isotope that we use for PET imaging, which is called FDG, which is a sugar analog, does have a role in a neuroendocrine tumor evaluation, but primarily that's restricted for patients who have higher grade tumors. So we use this concept of the Ki67 proliferation index. So patients who have Ki67 of less than 20% or lower or intermediate grade tumors, those typically express somatostatin receptors, so we would use the dotatate PET. However, for those patients who have higher grade tumors or a Ki67 of more than 20%, we would begin to use more and more FDG because they may not express somatostatin receptors as strongly. In this example that you're looking at, the same patient can actually have a variety of different types of disease where some express somatostatin receptors sufficiently and other ones don't. And especially in the kind of well-differentiated but high-grade group of patients, that's a Ki67 of 20 to 55%. Many people actually advocate doing both a dotatate and an FDG PET. But this is something that your local nuclear medicine physician will be able to kind of guide you through what types of imaging is needed. So now moving on to the therapy, again, peptide receptor radionuclide therapy, or PRRT, uses the very similar concept to what I showed you previously in the theranostics principle, and that once again, we have the same agent that binds the somatostatin receptor and that's linked to the radioisotope. In this case, it's a different type of radioisotope which gives off a radiation which will actually harm the cell, which is what we want. Just like on the imaging side, there are a variety of different radiopharmaceuticals that have been used over the years, but the only one that's FDA approved at the current time in the United States is the lutetium-177 octreottate, which has the brand name Lutathera. So all our radiopharmaceuticals that we give by intravenous injection actually work in the same way, but Lutathera is a good example of that, where once we give it IV, it goes and circulates throughout your body and then finds those cells that express the somatostatin receptors. It binds to those receptors and actually activates them so that the radiopharmaceutical goes inside the cell where it's trapped, and then it gives off this harmful radiation, which will slowly over time cause the cell to die off. The cell is affected, that's centrally has captured the radioisotope, but actually the adjacent cells that are in the same similar area are also affected by the radiation and can also be damaged. So that's a good thing because larger tumors will all be affected by this radiation, even if only a portion of the cells will actually express the receptors. But it's also harmful because adjacent normal tissue, such as in bone marrow or in the kidneys or in the liver, those normal tissues can also be affected by the radiation that goes outside of the cell. And that's actually leads to the major toxicity that we see. And primarily that toxicity is with the bone marrow itself. So the approval for Lutathera came through this phase 3 trial called NETTER-1, which was published several years ago at this point and was a large multi-center randomized trial for the efficacy and toxicity of Lutathera or lutetium-177 dotatate. This study design was for patients who had midgut neuroendocrine tumor that had previously been treated with standard dose octreotide but was progressing, and they weren't amenable for surgery any longer. So they were randomized in equal numbers to either receive the Lutathera plus continuing standard dose octreotide, or the comparison arm was high dose octreotide given every 4 weeks. The main endpoint, as you can see there, was progression-free survival, but there were multiple secondary endpoints for the study, including overall survival and response on imaging. This slide shows the primary endpoint of progression-free survival. The upper curve in green shows the results of the Lutathera patients on Lutathera, whereas the black line at the bottom shows the patients who received the high-dose octreotide. You can see that there's a big separation in those curves, which means that the Lutathera did have a big effect in improving the progression-free survival for those patients who were on it compared to those patients who received high-dose octreotide. In fact, the relative difference in those curves is a 79% reduction in risk of progression-free survival, which is certainly a good thing. The estimated progression-free survival is approximately 30 to 40 months with Lutathera compared to 9 months with the high-dose octreotide. So big difference there. One of the other endpoints was overall survival, and you can see again that the Lutathera did better than the high-dose octreotide, although the separation curves is not as big, but there is definitely an improvement in survival with Lutathera as well over the high-dose octreotide. So the last slide I'll show you from that trial is the objective response. What that means is, was there actually a reduction in size based on imaging? And in fact, there was. So 13% of the patients receiving Lutathera ended up having some reduction in size, but only 4% of the patients receiving high-dose octreotide did. So that was a big difference between the two. However, the other way to look at this is that actually only 13% of the patients who were receiving Lutathera actually had a reduction in the size of their tumors. So what I tell my patients is that, this treatment is really meant to just kind of keep everything stable. It's not really meant to make the tumors go away. So that's an important thing to keep in mind, is that whatever the subsequent follow-up scans show, as long as things are still stable, that's really the important thing and what we're trying to achieve for the progression-free survival. Okay, so how do we actually do this now that it's been approved and we can use this clinically? So these are some of the factors that we look at in choosing if this is the right treatment for patients. So the first thing, of course, is to look at the type of neuroendocrine tumor that you have and the grade of that tumor. So again, this is approved and now more widely for all patients with any type of GI neuroendocrine tumor. So whether of the foregut, midgut, or hindgut, and then also for patients with pancreatic neuroendocrine tumor, but it's not approved for patients who have other types of neuroendocrine tumors, such as from the lung or the kidneys or other areas. And again, because somatostatin receptors are expressed more strongly in lower grade or intermediate grade tumors, we try to reserve this for patients who have a Ki67 of less than 20%. But I will say that if there's sufficient expression of somatostatin receptors, even in higher grade tumors, then this may be a treatment that is appropriate for you. Just depends on some of the other factors listed below. So the next thing that we do, again, is to do a dotatate PET scan to make sure that there's sufficient expression of those receptors across all the tumor sites, and also to look for the distribution of the disease, because if the distribution is localized to one area, then this may or may not be the best treatment compared to some other options, whereas if it's distributed throughout your body, then definitely this would be the best option. Conventional imaging means either CT or MRI to look for progression of disease. We know, based on those results that I showed you, that this is a very effective treatment. So we don't want to do this too early. Also, I showed you that there isn't always a real reduction in the size of the tumor lesions. So if things are stable, then this is not the right time to do this treatment. But if things are progressing based on other imaging, then that would be the time to do it. And we, again, confirm where the disease is located, also based on a CT and MR as well. So those types of imaging kind of work together. And lastly, I mentioned that we do worry about some toxicity to the bone marrow and potentially to the kidneys or to the liver. And because of that, we do some baseline labs to make sure that you would be able to tolerate a small reduction in those areas rather than being already too low at the outset. So how we use this is basically as second or third line therapy once you've already been progressing on standard dose octreotide or lanreotide. And again, this is for patients who have metastatic disease that is no longer something that can be treated with surgery, and restricted to patients with GI or pancreatic primary neuroendocrine tumors that express sufficient somatostatin receptor expression. So that's the simple answer, but I will tell you that the details can be more confusing. We sometimes do the treatment for other subtypes and grades of neuroendocrine tumor. Also, we're not entirely sure what constitutes very strong somatostatin receptor expression. That's a simple statement to say, but in reality, there can be some variety in the different lesions across the body, and we're not sure whether we should use a specific SUV value on the PET scan or not. So things like this have still to be worked out. And I mentioned a few times that the distribution of disease can affect whether or not we choose to do this disease, and also the volume of disease as well. So these are the types of things that we discuss in our neuroendocrine tumor board, and that's something that's very important for this as well as other types of therapies that you're considering, is to have the case discussed in a multidisciplinary tumor board so that all different types of physicians can weigh in on these different aspects, and then everyone should be in agreement that this is the appropriate treatment for you at the appropriate time. The actual administration of the therapy is relatively straightforward, although it does take a fair amount of time. Lutathera itself is given over 30 minutes as a infusion, which is the most straightforward part actually of this whole process. But for the protection of the kidneys, we also need to give amino acids over 4 hours. We need to start that before the Lutathera and then continue that throughout the next 4 hours. So that's really what constitutes the most amount of time. And also those amino acids can cause some nausea, although the newer commercially available amino acids cause much less nausea than the older ones that were used for the NETTER-1 trial. But we do pre-medicate with some anti-nausea medication to help with that. And at that point, typically, most patients tolerate things very well. The nurse who will help you during the day is probably your main contact during this therapy. Although the nuclear medicine technologist and the nuclear medicine physician will also probably have a role during the administration of the Lutathera itself. The actual way we administer the Lutathera is shown in this diagram. The Lutathera itself comes in a vial from a pharmacy in New Jersey, delivered to all the sites throughout the United States. And we use this approach where we insert 2 needles into that vial. One of those needles is attached to saline and the other needle is attached to you. And so the saline basically flushes out the Lutathera from that vial, and then that goes into the patient. And the amino acids are also connected in that same way so that everything is delivered together. Some institutions, such as ours, use 2 separate IVs so as not to contaminate the amino acids with the radioactivity, but it can also be done through 1 IV if you use that system as well. So this slide shows how we prepare the room for this treatment. Of course, we're worried that if we do have a drop of the highly radioactive Lutathera onto the floor or in the bathroom, then that can cause a contamination. So we line the area around the chair and around the vial and in the bathroom with absorbent paper. And that way, if there is any contamination, then we can easily just capture that and clean it up. So this is for essentially our safety, not for your safety as the patient, but it is something to just keep in mind so that when you are in the room to receive this treatment, you aren't concerned about what you see in terms of this lining. It's really not concerning, but rather just for our safety. Really, the main area of contamination is the bathroom. And so even in the hospital, when receiving the treatment, it's important to try to be very careful when using the bathroom and not have any contamination or spills, and to wash your hands thoroughly and so forth. And by doing that, really, there's really quite little risk. The lutetium-177 that's used for the therapy also happens to give off some gamma radiation, which allows us to do a post-therapy scan immediately after the therapy is done. These are just examples of 2 patients that is showing what that scan looks like on the right-hand side compared to the original PET scan that was done on the left-hand side. The resolution is much poorer, but what it does is allow us to see that the therapeutic radiopharmaceutical did go to those same areas that we expected to see based on the pre-therapy imaging. And if we do this after every cycle, it also allows us to kind of just keep track of what's going on with the disease itself. I will say that this is completely optional. There's many sites that don't do this and other sites that do. And I think either way is fine at this point. We don't have enough data to know whether this is required or not. Of course, since you'll be radioactive, you need to take some precautions for the safety, again, of other people, not yourself, after this treatment is done. The actual exposure from this radiation is relatively low compared to some of the other radiation treatments that we do. Having said that, we recommend that you stay away from other people for approximately 3 days, and we especially worry about children or pregnant women. And as I mentioned, the bathroom is a major source of contamination. So once you leave and go home, or if you need to stay in a hotel or motel for 1 day, just again to be very careful in terms of using the bathroom, not to have any contamination there. We do recommend that you can fly the next day if needed, but if possible to wait for a couple of days. Of course, in the current era, that is not generally advised anyways, but it can be done certainly if needed. So all of that was discussed one therapy, but for the full cycle of the therapies, we do 4 cycles once every 2 months. And essentially, we keep to that schedule as long as there isn't any toxicity seen in your labs in the interim. So we check labs every 4 to 6 weeks after the therapy, and again, right before starting the next therapy. If we do see any toxicity, then we can prolong that duration and delay the next treatment cycle by a few weeks. And we can also give a reduced dose to help your bone marrow recover. Really, the main toxicity that we've been seeing is with platelets, which are the agents that help clot your blood. but there could be a theoretical risk to your white blood cells, which are important for infection control, or your red blood cells as well, which might give rise to anemia. Some places will also have you do interim scans or an interim follow-up with your oncologist. Again, those are very variable depending on the institutional practice. And also somewhat variable is the use of octreotide in between the course of the therapies. Some places do recommend it, other places only use it for symptom control. And again, I think there's not enough data to support one or the other fully. The approval of PRRT took a very long time, so you might think that we've kind of solved all the issues, but certainly not. These are just some examples of some of the future directions of PRRT that we still need to evaluate. One is if the patient initially did very well with the 4 cycles of the therapy, but then subsequently progresses at a future time, would it make sense to repeat the PRRT? Those studies are ongoing right now. Another example is if a patient primarily has only liver disease, we can actually give this agent through an artery that goes directly to the liver rather than giving it intravenously where it's going to circulate everywhere in the body to try to kind of reduce the systemic toxicity. Those studies are going on right now. Probably the biggest question is with regards to the combination of other therapies, whether to give this first or to give this later. And you can see there's a large number of different therapeutic considerations to keep in mind. And again, I mentioned that these should be discussed in a multidisciplinary board to best make these decisions. But there are studies ongoing in terms of looking at some of these sequencing questions. There are novel peptides that bind the somatostatin receptor more strongly than the current versions do. So that might be an avenue for future improvement. And other isotopes such as yttrium-90 or actinium-223, which is a alpha emitter, those might be more effective as well, especially for certain patient types. Those are under evaluation. And lastly is whether or not we should do personalized dosimetry to really calculate a specific dose for you rather than just giving a standard dose of 200 millicuries for every cycle. Those studies are ongoing. And lastly, I just want to close by mentioning, where we are with PRRT in the COVID-19 era. It's hard to make too many generalizations because there are so many regional and institutional variations in the practice, depending on how many cases there are of COVID-19 in a specific area and how full the hospital is. And of course, this can fluctuate over time. At the time of this recording, things are kind of beginning to be under control, but as the guidelines are being loosened, then there might be an increase in cases again. So this is a moving target. The best that I can say is to follow your local institutional practices. In most places, the PRRT treatments have continued, although in some cases, some deviations have been made. For instance, delaying the start to the treatment if the progression is not happening very quickly, or perhaps delaying some of the cycles for the same reason. Also, your family members may be asked not to accompany you, and then the actual administration of the therapy may be a little bit different in terms of personal spacing between patients and so forth. So you might see some small variations there. The biggest risk would be, again, the rare occurrence, a reduction in white cell count, which can lead to problems with infection control for you. So given this virus, if that were to happen, then you would want to be very careful in continuing the cycles of the therapy. But if that doesn't happen, which doesn't in the vast majority of cases, then that wouldn't really be an issue. But of course, since with this cancer and with COVID-19, you would want to, generally speaking, be very, very careful. But just follow your institutional guidelines. I refer you to this NANETS website. You can just Google NANETS and PRRT, and it will come up. And it's a great resource page. It has lots of information, including videos and downloadable information for you to look at if you have any frequently asked questions as well. With that, I will stop here. And I thank you very much for your attention, and also again thank the organizers for having me. I really appreciate the opportunity and look forward to any questions that you might have. Thank you.